Okay, so let's start. Hello, everyone. Welcome to Wisonic Global Webinar. This is Charlie, International Marketing Manager from Wisonic Medical. So today we are very honored and proud to invite Professor Kessler to share with us his latest research. Before we start, let me introduce our special guest, Professor Frank Law, medical doctor. He is the Dean of Department of Anesthesiology, Foshan Hospital of Traditional Chinese Medicine. His hospital is very famous in China for its orthopedic medicine and has one of the best regional anesthesia team in China. So now let's welcome Professor Fulong Luo to give us a very brief introduction for Professor Paul Kessler. 也欢迎国内的各位老师。今天呢，因为是英文授课，所以也请大家尽量英文提问。谢谢。那我们有请罗教授来给我们介绍一下 Kessler 教授。
Okay, thank you, Charlie, and thanks Wisonic for inviting me as a guest of today's Dandelion College online lecture. It's my great honor and great pleasure to be here as a guest, really. I once was a trainee specialized in regional anesthesia in Professor Kessler's hospital about 10 years ago, I spent 3 months there. I've learned a lot from Professor Kessler. Not only the detailed skills in nerve blocks, but also the principles, protocols, and clinical rules in regional anesthesia, I think which benefited me a lot in my later clinical practice. That's wonderful memories for me in all my life, really. Thank you, dear Professor. Now I'll give a brief introduction to Professor Kessler. Professor Kessler is board certified in anesthesiology, critical care medicine, pain therapy, and emergency medicine, and was awarded professorship in anesthesia in 1998. He received his specialty training in anesthesiology at Johann Wolfgang Goethe University, Frankfurt, Germany. Since February 2020, Professor Kessler is Vice Chairman of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital, Frankfurt. His clinical expertise focuses on regional anesthesia. He was co-authored over 100 peer-reviewed papers, review articles, case reports, and book chapters. Paul Kessler is a member of many national and international societies of anesthesia. From 2009 to 2014, he was chairman of the German Task Force of Regional Anesthesia. From 2009 to 2013, he was board member of the ISRA, and from 2014 to 2018, he was a German zone representative in ISRA Council. He is currently the chair of the ISRA Cadaver Workshops. He will give us a wonderful lecture later. The topic is Significance of the new Truncal blocks in regional anesthesia, a wonderful topic for all the anesthesiologists. Thank you, Mr. Kessler. Okay, now let's welcome dear Professor Paul Kessler.
Let's welcome.
Thank you very much. Thank you very much for the nice introduction.
Okay.
Now we'll begin our lecture.
Hello and good afternoon in Europe, good evening and good morning somewhere else in the world. My name is Paul Kessler. I'm member of the Clinic of Anesthesiology, Intensive Care Medicine and Pain Therapy at the University Hospital in Frankfurt, Germany. The topic I'm going to talk about today is significance of the new Truncal blocks in regional anesthesia. This slide shows you some of the most common Truncal blocks. in the thoracic area, these are the paravertebral block, intercostal block, PEX blocks, the serratus anterior plane block, erector spinae plane block, retrolaminar block, or the thoracolumbar interfacial plane blocks. And below you can see the first description of the block. In the abdominal area, we have transversus abdominis plane block, block, ilioinguinal, iliohypogastric block, fascia iliaca block, quadratus lumborum blocks, and the erector spinae plane block also. I will focus in my presentation today on the PEX block, serratus anterior plane block, erector spinae plane block, and quadratus lumborum block. Here you can see how often these blocks are found in the PubMed when you look at these blocks. And you can see the TAP block is one of the oldest blocks. First description came nearly in 2006, and you can see up to now we have nearly 1,000 publications of the TAP block. But you can also see that the newest one is the ESP block. First description comes from autumn 2016, and up to now we have nearly 500 publications on the ESP blocks. What is common to all these blocks is that these are interfacial plane blocks. These are no classical nerve blocks, though you don't need a nerve stimulator to do these blocks. You can do it in the awake or anesthetized patient. Most of the blocks are analgesic blocks and no anesthetic blocks. And what is also common to all these blocks, these are inconsistent in their success rate, and they have a low complication rate. We also have to constatate that for many of these blocks, we only have case reports or case studies, and only for a few ones we have randomized controlled studies or systemic reviews. These are no nerve blocks in the classical sense, and for most of them, nearly the ultrasound technique is the method of choice when you do these kind of blocks. Here you can see a cross-sectional through, and you can see where the probe is placed when you do the blocks. For the rectus sheath block, on the left side, the probe is placed just anteriorly. For the PEX or the TAP block, the probe is placed in the flank, and for some others, as the QLB or the ESP block, the probe is placed more closer to the midline. This here shows you how the block works. The target of these blocks are the thoracoabdominal spinal nerves. And the one part of the spinal nerve is the ventral ramus with the lateral cutaneous branches for the lateral side and the anterior cutaneous branches which innervates the anterior part of the trunk. And we have the dorsal ramus which innervates the muscle of the back and the skin of the back. And in addition, we have the sympathetic trunk, which communicates with the rami communicants with the spinal nerve. To understand what these blocks can do, it's important to know where you place your local anesthetics. Here you can see the spinal cord, you see the dorsal root and the ventral root, which form the spinal nerves, and you can see the sympathetic fibers from the visceral organs which communicate with the spinal nerves, and the spinal nerves end in the ventral ramus and the dorsal rami. If you place local anesthetics lateral from this line, so you will produce only a somatic analgesia. That means that you have an analgesia for skin, muscle, bones, and the parietal pleura and peritoneum. This can be achieved by the intercostal block, TAP blocks, PEX, rectus sheath block, ilioinguinal, erector spinae, and quadratus lumborum blocks. When you do these blocks, you will have an opioid-sparing effect, so these are only analgesic blocks. But if you place local anesthetics medial from this line, you will produce a somatic and visceral analgesia. That means, in addition to the former one, you will also have analgesia for the visceral pleura and peritoneum and the visceral organs. So This can be achieved by the spinals or thoracic epidural, by the paravertebral block. But what about erectospinal plane block and the quadratus lumborum block? If you have a somatic and visceral analgesia, you will have an opiate-free patient after the operation. But these blocks can also be used for a surgical anesthesia. You can do thoracic and abdominal operations without general anesthesia when you use only these kind of. So let me start with the PEX blocks, which are blocks for breast and chest wall surgery. We have three different kind of blocks: PEX 1, PEX 2, and serratus anterior plane. All these blocks are first described by Rafael Blanco, PEX 1 in 2011, PEX 2 in 2012, PEX 3 or serratus anterior plane block in 2000. Here you can see the innervation of the female breast. Important are that included are fibers from the cervical plexus, the supraclavicular nerves, from the brachial plexus, the lateral and the medial pectoral nerves, and the nerves from the branches from the spinal nerves, the lateral and the medial branches from the thoracic intercostal. This shows you what is important to know from the anatomical side when you do PEX block. You can see here the PEC major muscle, PEC minor muscle, the serratus anterior muscle, and you can see the long thoracic nerve and the lateral cutaneous branches and the medial cutaneous branches of the spinal nerves. For the PEX 1, you have to place a probe, the linear probe, just below the clavicle. For the PEX 2 blocks, you move the probe more distally at the level of the fourth rib, and the serratus anterior plane block is done at the level of the fifth rib in the mid-axillary line. The PEX 1 block will block the medial and the lateral pectoral nerves. The PEX 1 blocks has no skin innervation. Indications are plastic breast surgery, port implantation. Here you can see another anatomical view of the lateral and the medial pectoral nerve, and the probe is placed just below the clavicle. Here you can see the ultrasound picture of a PEX 1 block. You see the PEC major muscle, PEC minor muscle below the axillary artery and the vein, and the needle is advanced, in this case, from lateral to medial. And the end of the tip is placed in the plane between the major and minor PEX muscle. Here in this video, you can see how the local anesthetic is spreading in the interfacial plane between the PEX major and minor muscle. Easily to identify is the pectoral branch of the thoracoacromial artery, which lies in the same plane as the pectoral nerves. The next one is the PEX 2 block. With this block, you will block the lateral cutaneous branches of the intercostal nerves T2 to 6, the long thoracic nerve, which innervates the serratus anterior muscle, and indications are, together with the PEX 1 block, tumor resection of the breast or mastectomy. Here you see the anatomical picture. For the PEX 2 block, the probe is moved more caudally at the level of the fourth rib. This picture shows you the relevant zonal anatomy of a PEX 2 block. The local anesthetics is placed above as a PEX 1 block and below the PEX minor muscle. And the puncture comes from medial to lateral or from lateral to medial. The needle is advanced from medial to lateral. The first injection point is below the PEX minor muscle. Now the local anesthetic is injected in the plane between minor and serratus anterior muscle. The needle is retracted between the minor and major muscle, and this is a so-called PEG-1 block. The last one of the PEGs block is the serratus anterior plane block. With this block, you will block the intercostal nerves, T2 to 9, long thoracic nerves, the thoracodorsal nerve, which innervates the latissimus dorsi muscle, and the intercostal brachialis nerve. Indications for these blocks are, for example, major breast surgery or lateral thoracic wall surgeries. Here, the relevant anatomy. The probe can be placed in the longitudinal position in the mid-axillary line at the level of the fifth rib, or, what I prefer, in the transverse position in the mid-axillary line. With this position, it's easy to identify the origin of the latissimus dorsi when you move the probe posteriorly. There are two options to perform the serratus anterior plane block. First, you can do a superficial block when the local anesthetic is placed above the serratus anterior muscle, or you can do a deep serratus anterior plane block when the local anesthetic is placed below, or you can do a combination of superficial and deep. The question is, which blocks is more sufficient, superficial or a superficial injection or a deep injection? There are no clear data showing that one block is better than the other ones. In this publication from Biracha, he could show that the deep injection below the serratus anterior was more sufficient. Here you can see a scheme how the block is done. You see the latissimus dorsi muscle, the serratus anterior muscle. You can identify the ribs. You see the pleura, and you see the position of the needle for the superficial. Here, the needle is advanced for a superficial block. You see the latissimus dorsi is lifted up, and you can see on the left side, I show you again, on the left side you can see the thoracodorsal artery. After finishing this, you can do a deep SIP block. You can see here how the serratus anterior is lifted up of the sixth rib. What is the evidence for the PEGs blocks? This picture shows you a meta-analysis. PEGs2 blocks versus IV opioids for breast cancer surgery, and you can see that the oral morphine consumption is lower for the PEGs blocks compared to the systemic analgesia. Comparing the pain scores of the PEGs2 block with systemic opioids, the pain scores were lower during the first 24 hours at different time points for the PEGs2 blocks. In this study, the serratus anterior plane block was compared with IV opioids in patients undergoing thoracoscopic surgery, and the authors could find that also the worst pain was lower in patients receiving serratus anterior pain block, and also this patients were highly satisfied with the serratus anterior plane block compared to IV opioids. And another study showing also that the serratus anterior pain block was very effective as an analgesic after thoracic surgery. Here, this SAP block was compared to standard IV opioids, and also the pain scores and the morphine consumption were lower in the SAP group. Comparing PEGs2 with erectospinae plane block for radical mastectomy, the authors could demonstrate that for the PEGs block, the duration of analgesia and the morphine requirement in the first 24 hours was lower, and also the pain scores were postoperatively lower for most time points for the PEX block. And the conclusion was that the PEX2 was more effective than the erector spinae pain block in terms of postoperative analgesia after radical mastectomy. And this is not surprising, because with the PEX blocks, you also block not only the lateral cutaneous branches of the spinal nerves, but also the pectoral nerves of the brachial plexus, which is not the case when you do an erector spinae blade. Comparing the SAP block with the paravertebral block, where the systemic opioids for video-assisted thoracoscopic surgery, you can demonstrate that the paravertebral block and serratus block are equivalent regarding the morphine consumption, and that both blocks are better in pain scores compared to IV opioids. So there was no difference in this study between the paravertebral block and the serratus. And finally, in this study, where the serratus anterior plane block was compared with a thoracic epidural analgesia for thoracotomy pain, it could be demonstrated that the hemodynamic profile was more stable in the serratus anterior plane block. These are the rounded circles, and the pain scores are similar for both groups. So the conclusion from the study was that the serratus anterior pain block was safe and effective in treating thoracotomy pain. What are the indications for the PEX and serratus blocks? For the PEX unblocks, these are minor breast surgeries or pacemaker or port implantation. For PEX2 blocks, it's more invasive breast surgeries, radical mastectomy, and for the serratus plane blocks, major breast surgery, axillary lymphadenectomy, pectum excavatum, or the so-called NAS procedure, or thoracotomy, or rib fractures. What are the clinical applications and the conclusion for the practice? The mode of action of all these blocks is very clear and understandable. We already have some randomized controlled trials showing the effectiveness of these blocks. You can use ropivacaine in a dose, in a concentration of 0.2 or 0.5%, or you can use bupivacaine. For PEX1, you should use 10 ml of local anesthetic, PEX2 20 ml, and for the serratus anterior plane block 20 to 40 ml. If you perform bilateral blocks, you should not exceed the recommended maximum dose of local anesthetics. Otherwise, last can be a problem. Catheter insertion is possible. If you insert catheter, you can use a continuous rate of infusion of 0.2% of ropivacaine and 5 ml per hour. Probably a continuous infusion is not so effective as an intermittent bolus. This applies for all kinds of truncal blocks. An intermittent bolus or intermittent injection of a higher bolus of local anesthetics is probably more effective and as a continuous infusion or a patient-controlled infusion mode. The block is very effective. We have comparative studies with thoracic epidurals and paravertebral blocks, and the complication rate is rather. Complications are allergic injections, intravascular injections, last if you do a bilateral block. Nerve injury is rare because in the plane where you inject the local anesthetics are the long thoracic or the thoracodorsal nerves. Vessel puncture should be also very rare because you should know where your tip of the needle is, and then you should avoid any kind of vessel puncture. And also pleural puncture or pneumothorax are very rare complications. The next topic is the erector spinae plane block. You can see here the erector spinae muscle, and this is not one muscle. The erector spinae muscle consists at least of 3 major muscle bellies: medial the spinalis, in the middle the longissimus, and laterally the iliocostalis lumborum muscle. from the outside to the inside, we can find below the skin, that you can see on the left-hand side, the latissimus dorsi and the trapezius muscle. Below these muscles, you can find the rhomboid major muscle, and below the rhomboid major muscle, there lies the erector spinae muscle, which can be seen on the right-hand side. This is the first description of the erector spinae plane muscles from 2016 from Mauricio Ferrero from the Kijijin group. And this were two case reports of a patient with neuropathic pain after rib fractures and rib metastasis. And the erector spinae block was done at a level of T5 and 20 ml of bupivacaine, 0.22% was injected, and they found a spread posteriorly and anterolaterally between 2.3 to 2. And they also found that the contrast dye could be shown in the area of the spinal nerves here at this level, and this would explain the covering of the anterolateral parts of the chest. We know now that we can do an erector spinae plane block not only in the thoracic area at a level of T5. The ESP block can be done higher at the level of C7, T1, and at the level lower T1 and in the lumbar spine area. So this block seems to cover everything. It's a so-called all-rounder among the truncal blocks. You can use it for analgesia after thoracic surgery and abdominal surgery and upper limb surgery. Depending where you do your block, you can cover an area starting from the cervical to the lumbar area. This picture shows you how the ESP block is done. You see here the dorsal ramus of the spinal nerve. On the left side, you can see it in the cross-sectional view. We use routinely a linear probe, which is placed paramedian in the longitudinal position, and the needle is advanced from cranial to caudal with the tip direction of the transverse process, and then local anesthetic is injected. You can do it with a patient in the lateral, sitting, or prone position. On the right side, you see here the ultrasound picture. And here you can see the video. You see the trapezius muscle, erector spinae muscle, the transverse process. The needle is advanced to the transverse process. And when you are in the correct plane, you can see the erector spinae is lifted off the transverse process. Catheter insertion is also very easy because you advance the catheter in plane and the insertion can be followed up very nicely with the ultrasound. The question is, how does the erector spinae block work? Here you can see a cross-sectional view. You see the erector spinae muscle, you see the dorsal ramus with a medial lateral branch. You see the ventral ramus, you see the sympathetic trunk, and you see the advancement of the needle to the transverse process in the local anesthetics is always blocking the dorsal ramus of the spinal nerve. The question is local anesthetic flowing into the intercostal space or the paravertebral space or the epidural space and producing by this complete somatic and visceral analgesia. Many cadaver studies were done to answer this question. This is one showing that when you look for the cadavers, the ventral rami are not stained with contrast dye. Only the dorsal ramus here on the right side in the picture are stained with contrast dye. So the conclusion was there was no spread of dye anteriorly to the paravertebral space, and the dorsal ramus involvement was posterior to the costotransverse foramen. This is another patient where 30 ml of bupivacaine with contrast dye were injected at T10, and after 90 minutes they made an MRI, and they found sensory loss of between T6, T12 over the anterolateral aspect of the left thoracoabdominal wall, and in the MRI the authors found contrast dye in the paravertebral space, in the intercostal space, and circumferential around the epidural. So there was a clear paravertebral and intercostal signal intensity showing that contrast dye or local anesthetic was in this. In another cadaver study, the authors compared a paravertebral block with an erectospinae plane block. They injected 20 ml of methylene blue at the level of T4, and they found that after an erectospinae plane block, only in 60% the injectate spread into the paravertebral space compared to 100% when they did a paravertebral block. So the spread into the paravertebral space was inconsistent. And many other cadaver studies were done to look for the mechanism of an erectospinae plane block, and you can see different results. Here you can see what you have seen before, only a dorsal spread and a spread around the dorsal ramus. In this study, they could demonstrate that local anesthetic, this is the light blue color, was found in the paravertebral space. Here also, this was the Schwarzman study. They found spread of local anesthetics around the spinal cord and in the spinal nerve. In this study also, local anesthetic was found in the paravertebral space and the intercostal space, and also here in this study. But you can see there is a high variability regarding the spread of local anesthetics when you do an erectospinae plane. What are the mechanisms of action of an erectospinae plane block? What are the results that we have from cadaver studies? We know that a spread occurs in the dorsal rami in a craniocaudal direction, which will result in a sensorimotor block of the dorsal chest wall. We also have seen an anteromedial spread into the epidural space, which results in a spinal nerve block. We have seen an anterior spread into the paravertebral space with a sympathetic block, and also a laterally spread to the ventral rami, which causes an anterolateral block of the chest abdominal wall. But the open questions that remains are if we can see dye or contrast medium within the paravertebral space, the intercostal space, or in the epidural space, does this automatically mean a well-working nerve block? I don't know. What is the evidence for the ESP? Reliable and validated is only that the ESP block the dorsal rami. Any additional block of nerves, such as the spinal nerves or the sympathetic nerve, is inconsistent and unpredictable, but it would be very nice if we have a block of these other nerves. What you can always see when you do an erectospinal plane block is the spread of local anesthetics in a craniocaudal direction. But more important is is there an anterior spread of local anesthetics so that the spinal nerves and the sympathetic trunks are blocked in the paravertebral space. Here, an anatomical picture when the erectospinae muscles are removed and you look from the back, and you can see beyond the erectospinae muscle there are a lot of many deep layers of intrinsic back muscles as the rotator brevis and longus, levator costarum, and you can see a lot of ligaments, mainly the superior costotransverse ligament, which is important and which runs from the transverse process to the rib. And in between and the rib, there exits the dorsal ramus, the spinal nerve. And this costotransverse foramen is very important because this might be one of the mechanisms how local anesthetics, this is injected here around the transverse process, enters the spinal nerve or the paravertebral spine. The discrepancy between patients and cadaver is partly based on the fact that the diffusion of local anesthetics in cadavers do not allow to examine the effect of respiratory movement or muscle tension or relaxation and body positioning if we do a block in the lateral position, the prone position, or in the sitting position. We also have comparative studies between ESP blocks and IV opioids for video-assisted thoracoscopic surgeries. And you can see here the fentanyl consumption, rescue analgesics, as well as the pain scores were better in the ESP block group. And this was a comparative study of ESP block and paravertebral block for thoracotomy pain, and you can see here similar results regarding the pain scores and less hypotension bradycardia in the ESP group. So the conclusion was no difference between both blocks, but a better side effect profile for the ESP. Erector spinae plane block can be also done in the lumbar area. For this area, you need a convex probe because it's a deeper block. You advance the needle to the transverse process and you inject your local anesthetics to block the lumbar nerves of the lumbar plexus. This is an example of the patient in the lateral position. And this is the ultrasound picture that you can expect. It's the same position of the probe that you also use for the lumbar plexus block when you do the so-called trident technique. You can see here the transverse processes, and the needle is advanced through the latissimus dorsi muscle and the erector spine. This is the video of a lumbar erector spinae plane block. You can see the tip of the needle is in contact with the spine, with the transverse process, and then local anesthetic is injected. And it's not so clear, as you have seen it in the thoracic area, that the erector spinae muscle is lifted up. There exist many case reports and case series of the use of the lumbar erector spinae plane block in patients undergoing hip surgery or proximal femur surgeries. We also have a study looking at the combination of lumbar erector spinae plane block and transmuscular quadratus lumborum, or the comparison of lumbar erector spinae plane block and transmuscular quadratus lumborum block for postoperative analgesia in hip and proximal. What are the clinical applications and the conclusion for the practice? The erector spinae plane block is a kind of paraspinal block which is performed more superficial and therefore less risky than a paravertebral block. Indications are all procedures where analgesia is needed from the cervical to the lumbar area. The mode of action is not yet fully understood, and we only have a few randomized controlled studies. If we have somatic and visceral analgesia, it depends on if local anesthetics is entering the paravertebral place or not. It's a high volume block, and usually we should use at least 20 ml of local anesthetics, for example 0.375 or 0.5% ropivacaine, or you can use also bupivacaine. The insertion of a catheter is possible. If you use a catheter, you can use ropivacaine 0.2% in a continuous rate of 5 ml per hour. regarding the effectiveness, more comparative studies are needed with the so-called gold standards. These are the thoracic epidurals and the paravertebral block. The complication rate is rather low. Limitations of these block and of the results and studies or case reports we have just right now are the variability and inconsistency of these block. My conclusion is that this block is a block with a high potential, and very important is that the most significant advantage of the ESP block is its simplicity and safety. The final issue of my presentation are the quadratus lumborum blocks. These are blocks where the local anesthetics is injected in the planes around the quadratus lumborum muscle. The quadratus lumborum muscle is a muscle which origins from the 12th rib, the transverse processes of L1 to L4, and the iliac first described as quadratus lumborum block 1 and 2 by Rafael Blanco already in 2007. A third option, the transmuscular quadratus lumborum block was, or tachia block, was first described by Jens Borglum in 2013. This picture shows you a cross-sectional view of a patient in the lateral position, and it shall explain you where the local anesthetics is injected for the different kind of quadratus lumborum blocks and how it may work. You can see here the vertebral body. This is the psoas muscle in front of the transverse process. In behind, there's the erector spinae muscle. This black area is the thoracolumbar fascia, the posterior layer, the anterior layer. This is the latissimus dorsi muscle. And here are the abdominal muscles, the obliquus, external, internals, and the transverse abdominis. Convex probe is placed in the flank of the patient. And if you do a QL block 1, the local anesthetics is placed lateral from the quadratus lumborum block. For the QLB2 block, the local anesthetics is placed posterior to the quadratus lumborum. And if you do a transmuscular block, the navel is advanced through the quadratus lumborum and the local anesthetics is placed in front of the local anesthetics. Nowadays, we shouldn't use no longer the nomenclature 1 or 2. It's better to use the nomenclature lateral, posterior, or anterior, because from this nomenclature you can derive the position of the local anesthetics. These are MRI constructions of spread of contrast, and you can see when you compare the lateral with the posterior block, you can see in the posterior block more of the contrast dye is spreading to the spinal nerves and probably also here to the paravertebral space. That means with the posterior block you will have a deeper and more profound block. You will also not also have a somatic, but also we will also find a somatic and visceral. Performing a transmuscular anterior quadratus lumborum block means that we inject local anesthetics between the quadratus lumborum and the psoas muscle, and we expect that the local anesthetics will not stay in the lumbar area, but will also flow into the lower thoracic area via the lateral and medial accurate ligaments. In this sagittal image of a cadaver, the yellow line represents the flow of the dye, and you can see that the dye is entering the lower thoracic area. The diaphragma is represented with the blue color, and behind the diaphragma you can see the local anesthetics. On the other hand, we know that after a transmuscular anterior quadratus lumborum blocks, some nerves of the lumbar plexus and branches of the lumbar plexus are consistently blocked, and this is not the case if you do an lateral or posterior quadratus lumborum block. Summarizing the data from the cadaver and clinical studies, we can say that after a lateral quadratus lumborum block, the dermatomes are covered from T12 to L1, after a posterior QLB from T9 to T12 L1, and after an anterior QLB from T6 to L3. The paravertebral space is only reached after a posterior or an anterior quadratus lumborum block, and the lumbar nerves or parts of the lumbar nerves are only blocked after an anterior quadratus lumborum block. The different quadratus lumborum blocks, the patient can be placed in a lateral position, and a convex probe is placed in the flank of the patient. What you can expect then is that you can see here the vertebral body and the transverse process. In front of the transverse process, you see the psoas muscle. Top of the transverse process, the quadratus lumborum muscle, and behind of the transverse process, the erector spinae muscle. Lateral from the quadratus lumborum, the latissimus dorsi muscle, and in front, the three muscle layers of the abdominal muscles. If you perform a lateral quadratus lumborum block, the local anesthetics is placed lateral to the quadratus lumborum. For the posterior, the local anesthetic is placed in between of the latissimus dorsi and the quadratus lumborum muscle. And for the anterior quadratus lumborum muscle, the needle goes through the quadratus lumborum and the local anesthetic is injected between the psoas muscle and the quadratus lumborum muscle. You can advance the needle from posterior to anterior or from anterior to posterior. Here, the lateral QLB block, you identify the three muscle layer, external, internal, and transverse abdominis muscle, and the quadratus lumborum, and the needle is advanced anterolateral. You can see here in front of the quadratus lumborum, the local anesthetics, the tip of the needle is placed, and the local anesthetic is injected. Here again, the typical picture you can see for the transmuscular approach. You advance the needle from posterior to anterior, and until you are in the right plane between the psoas muscle and the quadratus. Here the needle is advanced. Now we are in the right plane. You can see the distinction of both muscles. Here you can see the spreading of the local anesthetics between the both muscles. For the posterior quadratus lumborum muscle, you have the same picture. You see the vertebral body, psoas muscle, erector spinae, latissimus dorsi, quadratus lumborum, and the needle is advanced posterior to the quadratus lumborum in the plane between dorsi and quadratus lumborum. In this video, a needle tip tracking technology is used to identify the tip of the. When you are in the right plane, you inject the local anesthetic, and you see the distension of the both muscles, the latissimus dorsi and the quadratus lumborum. We also have some studies here for laparoscopic surgery. The comparison of the posterior quadratus lumborum and the lateral transverse abdominis plane block, and you could see the time until first rescue analgesia was used was much more longer for the QLB for the posterior quadratus lumborum compared to the lateral tub, and also you can see here that the thoracic dermatomes are more often blocked with the quadratus block. Here, the effectiveness of the posterior quadratus lumborum for cesarean section compared to IV opioids, and you can see with the posterior quadratus lumborum block, the morphine consumption was reduced and the patient had a lower pain score. A comparative study of the posterior quadratus lumborum with the lateral transverse abdominis plane block for cesarean delivery confirms that the quadratus lumborum block was more effective in reducing morphine consumption and demands up to 48 hours post-operatively. There's many other case reports or studies for different kind of operations. You can see here for total hip arthroplasty, the effectiveness of transmuscular quadratus lumborum block, again transmuscular quadratus lumborum block for iliac crest bone harvesting, for femoral bypass graft placement, What is the evidence for the QLB techniques? Indications for the lateral QLB are lower abdominal surgeries, for the posterior QLB lower and upper abdominal surgeries, for the anterior quadratus lumborum lower upper abdominal surgeries and hip surgery, which dose should be used, at least 20 ml of ropivacaine, for example, 0.375%, or bupivacaine. Catheter are possible. You can use a continuous rate of 5 ml per hour of 0.2 ropivacaine. What is the effectiveness? Comparative study are lacking. What are the risks and what are the complications? We don't know exactly. Let me summarize the significance of pec serratus erectospinal plane or quadratus lumborum blocks in regional anesthesia. First of all these blocks are interfacial blocks. That means these are not classical nerve blocks. The technique of choice when you're doing these blocks is ultrasound-guided technique. If you have an opiate-free or opiate-saving technique, depends on if you block only somatic or if you block somatic and visceral fibers. Effectiveness and spread of local anesthetic, we can say there's a lack of consistency. All these blocks are unpredictable, and even if we are with the needle tip in the right plane and we see that the local anesthetics is spraying in the interfacial plane between two muscles, we cannot say this block will work 100% or not. Effectiveness, there is a validation, is depending. What are the indications for these blocks? Major procedures, when more effective and riskier procedures are contraindicated, such as thoracic epidurals or paravertebral block due to anticoagulated patients, and also minor procedures when more effective or riskier procedures are not indicated. The complications rate is rare. Serious complications are really rare. And in anticoagulated patients, what shall we do with these kind of blocks? We have not yet recommendations so far, but to my opinion, we can follow a more liberal regimen than uraxial blocks when we do these kind of blocks. Thank you very much.
Hello. Back again.
Thank you.
Thank you, Professor Kessler, for your insightful presentation. So let's move on to next Q&A section, which probably takes 25 minutes. I've seen many audience to ask questions in here, but due to time limitation, I will choose some of them. So the first question is from a doctor. He is asking that in our clinical practice, we found sometimes it's difficult to provide perfect or acceptable analgesia for patients with pelvic fractures, such as fracture of ilium, pubis, sacrum, and acetabulum. It's quite difficult to pronounce a very professional vocabulary for me. It seems very difficult to cover all of the nerves innervating this area with a single block. So how is your opinion?
This is a very good question. I think it's difficult to answer. If you have a pelvic fracture or a difficult pelvic fracture, you have to block the lumbar sacral plexus. That means with a single peripheral nerve block, you cannot achieve a whole analgesia-free patient. you have to do at least 2 blocks, a lumbar, you have to block the lumbar plexus, and you have to block the sacral plexus. Of course, you can do it with one injection. This is an epidural. You can do an epidural block in these patients, but an epidural to place in patients with pelvic fracture is very difficult, because already the positioning of the patient to bring the patient in a lateral position after a pelvic fracture will be difficult. If you have a bilateral pelvic fracture, it's nearly impossible. If you have a unilateral pelvic fracture, you can turn the patient on the not fractured side, and then you can do your epidural, and you can place a catheter. But you also have to keep in mind the epidural may be a little bit contraindicated, because patients with pelvic fracture need a lot of blood, they need a lot of transfusions, and they are at a high risk of coagulation disorders post-operatively. And then, if you have done a neuraxial block like an epidural, or if you have placed an epidural catheter, there is a higher risk of an epidural hematoma. Therefore, if it's possible, you should do some kind of peripheral nerve blocks. As I mentioned before, you have to do, for a complete free analgesic patient, you have to do 2 blocks. Maybe you can do a lumbar plexus block. So you have to place the patient on the lateral side, and you can combine it with a high, very proximal sciatic nerve block. This will work, maybe. But indeed, it's a difficult decision. And in my practice, we sometimes also combine a lumbar plexus block, which covers only the lumbar area, with a anterior quadratus lumborum block, because with this block, you also cover the lower thoracic nerves, and these are sometimes necessary, because when you have the fractures at the level of the iliac crest, maybe a pure lumbar plexus block will not be sufficient.
Excellent, very detailed. Yeah. So the second question for you is, as we know, Truncal blocks are very effective in post-operative anesthesia. I wonder if it can be used as a main anesthetic method during surgery, like spine anesthesia or epidural anesthesia.
As you have seen in my presentation, most of the so-called abdominal thoracic truncal blocks are blocks which provides somatic analgesia. That means you can block the nerve for the skin, maybe for the bone also, but not for the deeper organs. And therefore, these are only suitable for post-operative analgesia. What you can do with these blocks, for example, iliac crest bonus harvesting. But if you want to use these blocks as a sole anesthetic technique without general anesthesia, you must provide with these blocks also, in addition to the somatic analgesia, also a visceral analgesia. And this can be nicely done only with the neuraxial blockades. But you can use also an erectospinal plane block, and maybe the posterior or anterior quadratus lumborum block. And we have a very few data for the thoracic erectospinal plane block using in patients undergoing radioscopic thoracoscopic surgery, that this can be used as a sole technique. But it's always a matter, you cannot be sure if this block will work. And this is also common to all these blocks. Even when you are with your tip of the needle in the right plane, and you inject your local anesthetics, and you can see the distension of the space between 2 muscles, so you are correctly in the right plane. You cannot be sure that this block will work 100%. This is completely different if you do an ultrasound-guided nerve block. When you see the nerve, you inject your local anesthetics, the local anesthetic is flowing around the nerve. You can say this block or this nerve is blocked by 100%. This is completely different with the interfacial plane blocks. This you have to keep in mind. So for me, my preference would be that you use these blocks more or less only for post-operative analgesia, not as a sole anesthesia technique.
Okay, very good. So The third question is also from the audience. He mentioned that Truncal blocks are often very good for superficial pain, but sometimes are poor for the visceral pain. So, what's your opinion about it? For example, like what's your optimal anesthetic protocol after the surgery of radical resection of rectal cancer and laparoscopy?
I think the question is, what is our technique for colorectal surgery, for major colorectal surgery? In the past, this was always done as an open surgery, and an open surgery is very painful. So the gold standard for an open colorectal surgery was in the past, and I think is still now, a thoracic epidural catheter. But nowadays, many of these blocks are done laparoscopically, and this means it's a so-called minimal invasive technique, and this is part of the so-called ERAS concept. It means intense recovery after surgery. Patients should be mobilized very early, and patients should have less pain. When you do for all laparoscopic procedures, you can be sure that the pain perception is much more lower compared to the open surgeries. And therefore, when you do a laparoscopic procedure, thoracic epidural would be too much. So we have now other alternatives. We have other abdominal wall blocks. So there are some studies show using the transverse abdominal spleen block or the quadratus lumborum block, or also the erector spinae plane block as a regional technique for analgesia after the laparoscopic colorectal surgery. And always, if you use these abdominal wall blocks, they should be part of a multimodal analgesia concept for postoperative patients. So you should use non-opioids, a lot of non-opioids as a base of analgesia. You should use perioperatively the Truncal blocks, and with these Truncal blocks, probably you cannot stop completely the pain. You cannot make the patient pain-free. So you have to use a small amount of opioids in addition to these patients.
Okay, we're good. So the next question is a very technique related. So he asked that no root block may be the most reliable approach to a energetic result in Truncal blocks, but sometimes local anesthetics often diffuse into the spinal canal, so which may be very dangerous and even lead to disaster. Is there any way to avoid this kind of a complication?
Indeed, when we do a spinal or epidural, we wanted the local anesthetic to go into the spinal to block the spinal nerve. And when we paraspinal block, that means we inject local anesthetics more or less close to the spinal cord or to the spinal nerve. And sometimes we want to have that the local anesthetics blocks the spinal canal. For example, when we do a paravertebral block, we inject around 10 or 15 ml of local anesthetic in the paravertebral space, and the paravertebral space is open to the intervertebral foramen. So we accept that when we do a paravertebral block, that the local anesthetics flow into the foramen intervertebral and also block the spinal canal. But this is not of clinical relevance. And I think if we do the paraspinal block, for example, the retrolaminar block, or we do an erector spinae plane block, we are moving more away from the spinal cord, and we are more distally from the spinal cord. And I think even if we can show or demonstrate in cadavers that some kind of local anesthetics is flowing into the spinal canal, the clinical relevance is, in my opinion, very low. So I have I think there exists nearly no data that this is a huge problem when you do the peripheral Truncal blocks and the blocking of the spinal canal.
All right. So the fifth question for you is that blocks for post-operative anesthesia after thoracolumbar surgery. So which one is better? block at the lamina or block at the articular process? Block within thoracolumbar fascia. So what's the difference among those different approaches?
I think the person who asked this question means block of the lamina. This is probably the retrolaminar block. The block of the articular process, maybe this is the thoracolumbar interfacial plane block, and the block within the thoracolumbar fascia, this is done by the erectospinal plane block. These blocks are the endpoint of injection of the local anesthetics is very close together of all these blocks. But for example, the retrolaminar block is a block mainly done in the thoracic area. The thoracolumbar interfacial block is a block for the lumbar area, and only the erectospinal plane block is a block which can be done in the thoracic lumbar area. So the clinical effect of all these blocks is nearly similar the same. It depends on the volume which I use, and it also depends how reliable with these blocks can be blocked the spinal nerves, and how reliable with these blocks can be blocked the sympathetic fibers, and therefore we can produce complete visceral and somatic analgesia.
Very professional, yeah, very impressive. Still, many audience from many countries to ask questions. So I get a list of like 30 of them. So I don't think tonight we have enough time for that. So, but I will choose some very important ones for you to answer.
Yes.
So next one, the same topic, like for columbar fascia block. There are two different orientations. The one is parasagittal, the long axis one, and the next is transverse, the short axis one, lateral to medial approach. So which approach do you prefer in your clinical practice? So why?
So in my clinical practice, I absolutely prefer the transverse approach to when I do a thoracolumbar interfacial plane block. I have no or less experience with the parasagittal approach. I think most of the publications also are based on the transverse approach for the thoracolumbar interfacial plane block.
Okay, good. The next one is from a doctor in Indonesia. So his question is that if we perform PAX1 or PAX2 for the breast surgery, should I do general anesthesia?
Normally in our department here, we use these blocks not as a sole anesthetic, but we use it in combination with general anesthesia, and we use it mainly for post-operative analgesia after breast surgery.
Okay. So what's the difference between them? So the PAX1, the advantage of the PAX1 and PAX2, the advantage of PAX2, there are any?
I think the PAX1 block is, I think, is a block which can be used only for very minor procedures. We use it, for example, the most we use it for port implantation in cancer patients. These are completely pain-free, but you have to infiltrate the skin, because the skin of the breast from is innervated by the supraclavicular nerve from the cervical plexus. So if you do a cervical plexus and you do a PAX1 block, you can do minor breast surgeries, but the PAX1 block does not cover any skin. So normally, usually we combine always PAX1 with PAX2 when we have a pain-free patient after breast surgery.
All right. Okay, good. The next question is about what are the reliable indications for a successful block of the posterior branch of spinal nerve with block at the articular process? The rise of erector spine muscle. Is there a point?
Yes, it's. I think we can block the posterior branch, the ramus posterior of the spinal nerve, with different kind of the so-called paraspinal blocks. This is the retrolaminar block. This is the thoracolumbar interfacial plane block, the erectospinal plane block. With all these blocks, we reliably block the posterior ramus of the spinal nerve. It means we have the skin blocked in the back of the patient and the skin of the autochthonous back musculature. If there is a preference to one or the other of these blocks, as I mentioned before, the erectospinal can be done at the whole length of the column vertebra, and the retrolumbar is preferentially done in the thoracic area and the thoracolumbar interfacial plane block in the lumbar area. But with all of these blocks, you consistently block the posterior, the dorsal or the posterior ramus of the spinal nerve.
Okay, great. So I think Professor Lau, do you have any comments on this? Professor Frank, you can open your microphone. Yeah, good.
Yeah, from the beginning, we usually block nerves, and today we block the faster, we perform the faster block. So today, by the lecture, we've learned a lot, and a lot of questions be answered by your lecture. Thank you, Professor.
Thank you.
Yeah. Okay, we'll continue. Yeah. Also, we have other questions, and the next one is about there are many truncal blocks currently under clinical practice. It is quite difficult for us to figure out which one figure out the essential relationship between them. So, can you just give us any ideas of this?
To answer these questions might be a little bit difficult because we have so many blocks, and nearly every week or every month someone is publishing a new kind of block with a new insertion of the needle somewhere else. We also have to keep in mind what I have shown in one of my slides, that we have, for many of these blocks, we have a lot of case report or only case series, but these logs are not validated yet. That means we need, if we want to say if a block works very well for a special kind of operation, we have to compare this block against systemic opioids. This is the first, and then we have to do comparative studies with this new block compared to the old-fashioned blocks for this kind of operation. And then when this block will works very well, and it will show that this block works better, then we can say this is a very new, well-working block. So I think when I look at all the new thoracolumbar abdominal wall blocks, for me, the erectospinal block has the potential to become a very interesting block because we can use it for so many different kinds of operations. And especially in the thoracic area, it is a very superficial and a very easy block. And you can see very nicely the needle, and the advancing of a catheter can also be very nicely seen. And this thoracic erectospinal plane block has a very low risk profile. So this is for me a block maybe with a high potential. And also in the thoracic area, you can do this block for major upper abdominal surgeries. So also for these kind of procedures, when more riskier blocks like the thoracic epidural is not indicated, this block can be done. So we do, for a lot of minor abdominal surgeries in our department, we do this block bilaterally, but you have to keep in mind, when you do it bilaterally, you have to take a high volume of local anesthetics, and then the patient is at a higher risk of systemic intoxication. But sometimes I hear a lot of criticism about the new Truncal blocks, because these blocks are all interfacial blocks. That means you need a high volume. All these blocks are high volume blocks, especially when you do these blocks bilaterally. And this is indeed in contrast to our practice with ultrasound. When we use ultrasound for nerve blocks, one of the major advantages compared to nerve stimulation was that we can reduce the amount of local anesthetics to nerve stimulation so far. And now we are, for example, when we do an interscalene block with nerve stimulation, we have to use around 40 ml of local anesthetics. Now, with in the area of ultrasound, we can use 8 to 10 ml of local anesthetics. But now, when we are talking about the interfacial plane blocks, which are blocks, most of them are created in the area of ultrasound, we have to use a large amount of local anesthetics, 30, 40 ml. And if you do these blocks bilaterally, we have to use 50, 60 ml of local anesthetics. So we have to keep in mind this, that patients with these interfacial plane blocks, these newer blocks, are at a higher risk of local anesthesia intoxication.
Yeah, good. So let's move on to the next one. Because there are many beginners who start to learn Truncal blocks, they want to get advice or suggestions from you for some important tips and take-home messages. So do you have suggestions for them?
First of all, you must know you must know your machine. You must know how to do an ultrasound guided block. You must always know where is the needle tip. This is, for example, one of the reasons why the incidence of nerve damage is not lower up to now compared to nerve stimulation when we compare ultrasound with nerve stimulation, because many of the users of the ultrasound technology do not know when they advance the needle, where is the needle tip. The second is you have to know to use the right block for the right operation. And for my advice would be, because we have so many of the thoracoabdominal wall blocks, you should focus on one block for thoracic procedures, maybe one block for abdominal procedures, and maybe also we have alternatives also for lower limb blocks, for example, when we do hip surgery. For the thoracic area, probably the erectospinal plane block is a good block to learn. Maybe also the PEX blocks or the serratus anterior block. Serratus anterior block is also a very good alternative for chest pain. And for the abdominal wall block, you can use also the erectospinal plane block, or you can use the TAP block, even if you know that the analgesic potential of the TAP block is not very low. But if you use a TAP block, and compared to a patient with no TAP block, you have an opioid-sparing effect of around 30%, and this can be important in some patients. And for hip surgery, for example, in the past we used lumbar plexus block or femoral nerve block, but we have a lot of alternatives for hip surgery, for major hip surgery. We can use a suprainguinal fascia iliaca block, or we can use an anterior quadratus lumborum block, or we can do a lumbar erectospinal plane block. Lumbar erectospinal plane block and the anterior quadratus lumborum block, these are blocks we do more and more often in patients undergoing major hip surgery.
Yeah, very useful information for all of the beginners who start to learn Truncal blocks. There is a question from the audience directly. He's asking, regarding of the this is very difficult pronunciation vocabulary. I will try my best to pronounce it. So, what's the best approach for nephrectomy? Nephrectomy. Yeah, I think it's
nephrectomy for kidney.
Yeah, kidney relating to
for kidney surgery. Yes.
Yes, kidney surgery. Yes. The patient
for major kidney surgery, nephrectomy. What is the question is, what is the appropriate or the best approach for the
best for nephrectomy? A patient
nephrectomy, yes, for nephrectomy.
Patient posterior or lateral. So, what's your experience of catheter insection with TLB?
For nephrectomy, the gold standard in the past was the thoracic epidural, because it's a very painful procedure. With every breathing, the kidney are placed just close to the diaphragm, and with every breathing you will feel pain. Therefore, patients need a real well-working block, and in the past, thoracic epidural was a gold standard. But now in our department here, we move away from the thoracic epidurals. We move to thoracic erectospinal plane block, or you can use also an anterior quadratus lumborum block. And you can also use, I think the thoracic erector spine is more appropriate because the quadratus lumborum block is placed more closer to the operation side, and the thoracic erector spinal plane block is a little bit more away. And even when you place a catheter, it doesn't hurt the operation. So these are the two options, two real very good options in patients undergoing nephrectomy.
All right, very useful information for the anesthesiologist who want to do such kind of a surgery. Yeah. So I don't think we have enough time, but I got the last question for you. Okay. I think time is up. So the last question is about, would you choose one of QLB or a fascia iliaca block for a neck of femur fracture or hip replacement? Is regarding of hip
Yes, I think I answered partly this question with my last answer. For major hip surgery or hip neck fracture, I think the suprainguinal fascia iliaca block is an attractive alternative, and also the anterior quadratus lumborum block, or the thoracic or the lumbar erectospinal plane block. These are three alternatives for the these are analgesic options, very well working analgesic options in patients undergoing major hip surgery or proximal femur fracture or something else in this area.
Okay, very professional. Yeah. Okay, I think time is up. So let's say many thanks to you, Professor Paul Kessler, and to Professor Frank Law, and also thanks to all the audience who are with us today. It's time to say goodbye. So wish you all have a pleasant day, nice day. So if you want to follow Wisonic, we have Facebook or LinkedIn for all of us to follow all of the webinars in the coming days. Do you have any comments, Professor Kessler?
No, thank you. I would like to thank Wisonic for organizing and inviting me for this webinar. I enjoyed it very much, and very, very interesting questions from the audience. Thank you very much.
Thank you. Thank you.
Thank you for Professor Lowe for the nice introduction also. Yes.
Yeah.
Okay, yeah.
Bye-bye. Bye-bye. See you next time.
Bye-bye. Yes, bye-bye.
Bye-bye.
It's finished now?
Yeah, it's finished.
It's finished now.